This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for our HealthyU Webinar Series. Today's topic is symptoms of heart disease and heart attacks on women. At any time during the presentation, please feel free to answer any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is Claire Odenthal. Claire, I'm going to bring up your PowerPoint now, and then I'll hand it over to you.
Thank you, Jonathan. Okay. I'm just going to start. My name's Claire. I'm a nurse and a nurse practitioner for many decades. I've worked in cardiology for a long time and have dealt with both women and men, obviously. And this is close to, ironically, my heart, women and heart disease. So, and it is Heart Month. Next slide. So back in 2003, this was the headline in Time magazine, which is now probably online. Women and heart disease is your biggest worry, breast cancer. Think again, 1 out of 3 women will die of heart disease. And I think this education started back then. Some of the women that I started working with, some of the female cardiologists that I admire and started working with that were breaking the ceiling to into cardiology were part of this big push. But this still holds true that not sure all women are aware 21 years later that women in heart disease are a real cause of death for women. Next slide, please. So what's heart disease? Heart disease is also referred to as cardiovascular disease. And we often think of heart disease as just coronary artery disease or blockage. And that's narrowing of the arteries. A full narrowing of the arteries where there's an occlusion is a heart attack. But heart disease also includes heart failure, where the heart's not pumping normally, heart muscle disease, where the muscle is weak for many reasons. And that's called cardiomyopathy, which sometimes we interchange with heart failure, heart valve disease, pericardial disease, which is the sac around the heart, aortic valve disease, spontaneous aortic dissection, which you'll hear the word SCAD, which is more common in women, arrhythmia or abnormal heart rhythm. And then we also have peripheral artery disease, which is in the legs and in the extremities, stroke, which is part of the cardiovascular system in the brain, and congenital heart disease, where we're born with a problem or holes or problems with the heart as a child, at birth. And then you have pulmonary emboli, which is part of the vascular system, which is a clot into the lungs. And then we have deep vein thrombosis, which is a clot in the veins of the legs, and rheumatic heart disease, which is not as common, but not completely eradicated in the United States, but is more common in developing countries, which attacks the valves, and stress-induced cardiomyopathy, which is very specific and more common in women. Next slide, please. So just to give you an idea of, in a picture sense, I'm all about pictures. This is all the areas that I'm talking about, from the top of your head all the way down to the periphery, which I couldn't find a woman's picture that showed all the way to the legs. But the heart is at the center of this, pumping blood, and the red is the arteries and the blue is the veins. So The brain is involved, the pulmonary or the lungs are involved, the periphery is involved, the kidneys are involved, and all our organs get oxygenated blood as part of the cardiovascular system. Next slide, please. So as I said, I'm a visual girl, so this is what some of the heart diseases look like. A heart attack is a narrowing. Heart failure is where the pump itself doesn't work very well. The whole muscle is weak. Cardiomyopathy is a whole class of heart diseases, rheumatic disease, arrhythmia, also known as irregular heart disease, angina, and then stroke, which is blockage in the arteries in the brain, and coronary artery disease, where there's blockage, but it's not caused a full heart attack. Next slide, please. So what causes cardiovascular disease for male and female? Hypertension, also known as high blood pressure, diabetes, which is prevalent. Family history, and this is part of my wheelhouse as most physicians and nurse practitioners. We have to find out what the family history is. What's the genetics of this? It really gives us clues to how to figure out the problem of what's happening with the patient. Smoking history. Smoking really puts our patients at risk for cardiovascular disease in all the categories. High cholesterol, obesity, and sedentary lifestyle. These are for both male and female. And for the most part, I think most of the population knows that these are the general risk factors. But let's talk about women specifically, which I don't think is really spread the word. Next slide. So female-specific cardiovascular risk factors. So in younger women, menarche, polycystic ovarian syndrome, oral contraceptives, preterm menopause, so you go into early menopause. In pregnant women, I'm not sure that all pregnant women know that when they get diabetes and high blood pressure, they are at risk for having heart problems later on in life, as well as preeclampsia, which is severe high blood pressure, and preterm birth, which I'm not sure these are things that the GYN doctor is saying, you know, you're at risk, you should keep an eye on this. And the same for older women going into menopause. They are at higher risk for having cardiovascular. So there is some benefit of getting our period, and then once we, there's some cardioprotective piece to getting our period, and then once we go into menopause, we're at higher risk for cardiovascular events, as well as hormone replacement therapy, which has been studied. Next slide, please. So just to go into more risk factors specific to women, hypertension, also known as high blood pressure, is often undiagnosed in women and under control in fewer than 1 in 4 women with high blood pressure, which is HBP. So more than 56 million US women have high blood pressure. And I suspect there's more, but it's not being diagnosed. High blood pressure in pregnancy also increases heart disease risk later in early onset of menopause and menarche. And diabetes during pregnancy, as I discussed. Women are more likely to have frequent adverse cardiovascular outcomes related to depression and anxiety than men. And oftentimes that I've seen over my career that the depression and anxiety get labeled and they forget to look at the risk factors for cardiovascular disease. And in fact, this woman is having a cardiovascular event and they're being labeled as anxious. Inflammatory and autoimmune disorders affect women disproportionately and increase the risk. Next slide, please. So heart disease in women is the leading cause of death in the US in both men and women. In 2020, nearly 300,000, I dropped off a zero there, women died of heart disease, about 1 in 5 deaths that year. So that's a huge number. And if you think about it, when I was looking up breast cancer, it's 42,000 deaths in a year. So the amount of heart disease that can happen is significant. And the perception is that heart disease is primarily a man's disease, has large implications and misconcepts. Awareness of heart disease as a leading cause of death started in 2003 and declined from 65% in 2009 to 44% in 2019. So we dropped the ball somewhere in trying to educate women and men who live with women about what their risk factors are and recognizing heart disease as a woman's disease. In 2014 study, only 22% of primary care doctors and 42% of cardiologists felt extremely well prepared to assess women's cardiovascular risks. That's concerning. I know it was 10 years ago, but I'm hoping that some of those numbers are better. When considering all cardiovascular diseases, 57% of stroke deaths in the US are women. So more than half are women. And that I don't think is, even I, when I was doing research on this, didn't realize, I thought it was about 50-50, but women are in the higher category. Next slide, please. So women are more likely to die from heart disease than men. And why is that? Because it's not recognized, we're older, we come late. So despite outreach efforts, 45% of women still don't know that heart disease is the leading cause of death in the United States. So I'm glad whoever's here is hopefully spreading the word that they should get their heart checked first. Women are less inclined to call 911 when they believe they are experiencing a heart attack symptoms. And for having done this many years, what I've heard from thousands or hundreds of women say, well, I didn't want to bother the kids. I thought it was going to go away. I didn't know. It wasn't a good time to call. I thought it would go away. So cardiovascular disease complicates up to 4% of pregnancies, and that number has been increasing. Women's heart attack symptoms are different from men's, and 40% of women having a heart attack experience no chest pain. 40%. That's 4 women out of 10 don't recognize it. And they may experience shortness of breath, nausea, palpitations, jaw discomfort, or an overwhelming fatigue. Next slide, please. So other sex differences, starting menopause before age 40. So I said that our period was somewhat cardioprotected or somewhat protected. But if we go into early menopause, we are at higher risk. Endometriosis and polycystic ovarian syndrome put us at risk. Hormonal disorders that affect the ovaries, and autoimmune disorders. And why is that? The rheumatoid arthritis and lupus that affect a large, not that they don't affect men, but they do seem to have a higher population of women, that cause plaque to build up faster in their arteries and lead to worse outcomes following a heart attack or stroke. And what I've seen with my rheumatoid arthritis women is that they think that the pains and aches that they are having is their arthritis. It's just a bad day. Next slide, please. So 70% of women ages 25 to 60 get an annual physical. So it's still only 70%, but out of that, just 40 report having had their heart health assessed during these visits. And I don't know whether that means an EKG or whether a doctor is looking at listening to their heart or having their cholesterol checked, but that's not a great number and we need to improve that. During pregnancy, hypertension is the most common acquired medical condition, and congenital heart disease is the most common pre-existing condition. And women experiencing heart attacks are less likely to receive recommended medications to treat it, or they get them much later compared to men. And this needs to be looked at. Every second counts during a heart attack, and time is muscle the longer we wait to treat a heart attack, the more muscle that it has declines. And women are less likely to be referred to cardiac rehab after a heart attack. And I'm not sure if this is our own problem where we say, no, I don't want to do that, I'm too busy. Next slide, please. The incidence of maternal cardiovascular disease appears to be growing. So why is that happening? Women are getting older, they're in the workforce longer, so their cardiovascular risk factors go up, and they are having babies later. And the lifespan of patients with congenital heart disease is going longer. We're doing good with the congenital heart disease patients, but now we have to deal with how to manage them as they get older. The pediatric cardiologists now need to teach general cardiology what's happening. Women's heart disease is under-researched, and we've utilized a lot of the research from what men and applied it to women. Only 35% of participants in clinical trials of cardiovascular disease are women, and just 31% of the studies report outcomes by gender. Death rates due to heart disease increased last year for the first time since 1993. And death rates have been increasing in young women 29 to 45 since 2000. And preeclampsia is an independent predictor of cardiovascular disease later in life, and women who've had preeclampsia should be mindful of having their blood pressure checked, fasting glucose and cholesterol checked annually. Next slide, please. So what do women look like when they have their heart attack? They can have similar symptoms, but they also get neck, jaw, shoulder, upper back, upper belly, which discomfort can appear to be gallbladder or something in the GI tract, but it's a heart attack. Shortness of breath, they may feel they're getting out of shape. Pain in one or both arms, they maybe overdid too much and they don't recognize it. Nausea or vomiting, I've seen patients, I thought I just had a virus. Sweating, they break into a sweat. Lightheaded or dizzy. Unusual fatigue, I'm not sure about any other woman, but I'm tired a lot. So to be fatigued would not be a red flag for me. And heartburn, indigestions. I just ate a big meal. I'm just going to take a Tums, and they keep going. Next slide, please. So just a visual, as I said, I'm a visual girl of things that chest pain, cold sweat, dizziness, vomiting, irregular heartbeat, also known as arrhythmia, feeling pale skin. A woman said that their family member said they looked pale today. They didn't recognize that as a warning sign. Shoulder and back pain, nausea, and shortness of breath. Next slide, please. So gender differences. So atherosclerosis, the buildup of plaque in the arteries that leads to a heart attack and stroke. So surprise, the plaque in men and women differs in the size of the plaque and where it is found and how vulnerable it may be to rupture. So again, we've been studying men and applying some of the men studies to women, and the plaque is very different. Women are more likely than men to have a heart attack caused by plaque erosion, spontaneous coronary artery dissection, also known as SCAD, and other problems other than obstruction, which I showed you in the first slide. There's other things that lead to a heart attack. Men are more likely to have heart attacks caused by rupturing plaque in their arteries. Next slide, please. So what is coronary artery disease? And so the squiggly lines on this heart are the veins and the arteries of the heart, and on the screen next to it is, as it's labeled, healthy artery, fatty deposits as we get older, and I don't mean older, that fatty deposit in the second picture starts in our 20s, and then plaque starts to obstruct, and then nearly occlusion, which is a heart attack. And this has always been the cartoon picture that I use to describe to my patients what coronary artery disease looks like, but it's just a cartoon. When you break it down, next slide, please. The plaque inside the vessel itself looks very different in men and women. And plaque ruptured plaque has a different look. It's got a thin fibrinous cap, it's got large lipid core, which is fat, it's got macrophages, it's got a clot. And in women, it can look more like an eroded plaque. It's got protein, it's got a little or no lipid core, neutrophils, many smooth muscles, and a platelet-rich thrombus. So I'm not saying that men and women can't have the other, but in general, the eroded plaque is more susceptible for women. Next slide, please. So heart attack symptoms, they cross over. So as these two people connect and cross over, you can have both, women and men can have both of all of these symptoms, but more common in women is the extreme fatigue, the lightheadedness and dizziness, the neck and jaw, often without chest pain, the upper back, the shortness of breath, the chest pressure, vomiting, nausea, heartburn, and indigestion, and discomfort or tingling in one or both arms. And men can have the cold, and women can have the cold sweat, the tingling in the back and the jaw, and chest pressure and pain and shortness of breath and nausea. Next slide, please. So why the disparities? The prior studies report women are getting less often life-saving procedures during a heart attack. Women less likely than men to be prescribed aspirin, statins, ACE inhibitors. The medical community needs to do better, and I'm part of that, so I'm dedicated. Inclusion in cardiovascular trials critical to overcoming disparities. We need to get women involved in these studies. Women, especially underrepresented in heart failure studies. So we need our heart failure docs to include the women. And barriers to inclusion. So why aren't they involved? So if we go back to the beginning slides, we're not referring our ladies to the cardiologists or specialty programs. Is it the primary doctor's fault? Where's the problem? We need to look at that and be aware. So education is key. Lack of awareness, trust, or logistical barriers. Not sure whether they have the time to go to a cardiologist. Oftentimes we can't get there because the good cardiologist is on the other side of town, and I got to take care of everybody else in the family. Underrepresented in clinical trial leadership. So we need more leaders in clinical trials to try and use very specific women's studies. And pregnant women are often excluded from research, which I'm not sure why. So we need to get the pregnant women on board. Next slide. So just to recap some questions, and I'll answer them obviously. So coronary heart disease develops gradually over many years. It can easily go undetected. True or false? The answer is true. Next slide. Women don't worry about cardiovascular disease. It's mainly a problem for men. Hopefully at this point, after listening to me for the last few minutes, you know that that is false. Next slide. If a woman has a heart attack, they're more likely to survive than a man. And that is also false. Next slide. Women are less likely to get heart disease after menopause than before. And as I've said several times, that is not true. That's false. When men reach middle age or about 55, their blood cholesterol levels start to rise. But cholesterol levels of women seem to stay about the same. Wouldn't that be lovely? And that is completely not true. Next slide. African American women are more likely than white women to have cardiovascular disease. And this is another disparity where we're not only addressing, applying everything from men to women, now we're applying all ethnicities the same treatment. So that is true. Next slide. Women who smoke are 3 times more likely to have a heart attack than a woman who doesn't smoke. And that is true. Next slide. Which of the following is the single most important thing a woman can do to reduce their risk for heart attack? Reduce stress, start jogging, reduce salt in their diet, or quit smoking? And the answer is D. Of course, we'd like you to do everything. I'm not sure everybody's going to start up jogging, but quit smoking is the #1 thing to do. And I often tell my patients that trying to change all their habits all at once is a setup for failure. If you try to quit smoking, you start jogging, and change your diet all at once, you need to take one thing at a time. Next slide, please. So women can reduce their risk for heart attacks and stroke by following which of these lifestyles? Quit smoking, exercise regularly, eat a healthy, low-fat diet, and the answer is all of the above. Next slide. So this is, again, as I said, I like the pictures. This is a full circle of life. I feel like women, or myself in particular, are very much about the circle. We need to circle back to everyone in my life, but everything needs to come around full circle. So drink a little less alcohol, try and reduce stress. That's hard. We put everybody else first, try and manage our cholesterol. Manage your blood pressure. Try and stay on top of your blood sugar if you're diabetic. See your GP for a heart health checkup, and encourage him to refer you if there's things out of whack. Follow a heart healthy eating pattern. The web and the internet, Google, that gives you a lot of recipes. It's not hard to get information out there. We need to get moving. It doesn't take a lot of movement. You can move 10, 15 minutes a day, and that has good cardiovascular benefit. Try to be smoke-free. It's a very hard habit to quit, and we encourage everyone to keep trying. Maintain a healthy weight. The up and down is worse than maintaining at least a steady state. So this is the 10 steps to protect your heart, but also to try and maintain good heart health. Next slide, please. So what do we do? This sounds all negative, right? So, oh my gosh, we haven't been studying women, but we're working on it for the last 21 years. And what do we do? The framework for action to eliminate disparities in cardiovascular health. So we need strategic imperatives. So that's a lot. So accelerate health impact in disparate populations. So we need to try and hit populations where the cardiovascular risk factors are high and death rates are high. Advance policy and system change. So we need to work on what our healthcare system, which is trying its best to get in better policies. Form strategic multidisciplinary partnerships. So what does that mean? That means like we need our GYN to talk to our general, to talk to our cardiologist, to talk to each specialty needs to have more conversations and be interspersed with each other. Expand community-based participatory research and translation. So we need to hit the community and then make it simple, and then bring it not in these large medical terms, but very easy language. And then how do we know what we're doing works? We have to get boots on the ground to collect health data about specific race, ethnicity, and disparity indicators. Just because we think, I think that when studies were done on men, they assumed that it was going to work for women, and that assumption was wrong. And that same assumption needs to be looked at and said, all right, well, if it works for one race, is it going to be applied to all races? And as we have already seen with men and women, that's not accurate. Ensure a diverse clinical and public health workforce. So everyone can't look the same. We have to, who's in the workforce, they need to have people to relate to. Next slide. So that's the strategic area. Now let's address the focal areas, or the local drugstore. Access to healthcare, pardon. Is there some place for somebody to go in a poor neighborhood? And there's the quality of care. So there may be a doc in the box, but is that everybody's found out that that doc in the box, that guy stinks or the woman stinks? Patient preference, healthcare utilization, adherence, cultural lifestyles, and personal behaviors need to be taken into effect. Regulation, policies, and systems. Location and environmental influences. If you can't get to the doctor because you have to feed your family. Income and educational levels. We need to hit the schools early, and we need to talk to children at a young age. And then everyone brings prejudice, discrimination, and biases to incorporate it into their practice. We're trying to get rid of those prejudices, discrimination, and bias, and really educate ourselves as healthcare providers. And then the psychosocial stressors. And then what is biology, genetics, and the environment do to us? And that needs to be looked at. Next slide. So we need to look at the communities, the cities, the regions, the states, schools and colleges. Where's the education happening? Start small and go big. And work sites, hospitals, hopefully like webinars like today. We need to get to churches. If people are going to church every day, and synagogues and mosques, we need to offer it there where people have time, right in. We need to bring this information to the people. Next slide. So what can we do as mothers, daughters, aunts, grandmothers, women? Number one, come to a webinar, educate yourself and women in your family. Women are great at questioning, and I want them to question their doctors. I want them to support each other. And I think that we need to do self-care. We help and take care of everyone else, but ourselves. So we need to put ourselves first, and that's very hard. We put everybody else first. And then spread the word among friends and women in your tribe. Next slide. So a lot of information on the web. And if you want to go on the computer and do a little risk calculator and bring that to your doctor, your primary doctor, you can say, this is my risk factor. I couldn't get it to work, but it calculates your 10-year risk based on a lot of information. And you could bring something like this to your primary doctor and say, do you think I need a referral? Next slide. So there is support out there, and the Women Heart support groups have been, this Women Heart has been around for many years. And it's a nationally patient-centered organization dedicating to advancing women's heart health. It's run by women that have had heart problems. And it is, I've gone to these meetings where the women in the groups support each other, and it's peer-led. It's not led by someone like me. I was invited to these groups to answer questions, but it's all about supporting other women who have gone through heart conditions. Also, there's at the Katz Institute for Women's Health, which is part of the Northwell, which is on this website. They're starting a big initiative to really focus in on women's health and get studies. So the train is moving towards really looking at women as a very specific, as it should be. As 21 years ago, we started this education process, and the Women's Katz Center is really taking it by the lead. And women that I started off in cardiology with are in these leadership roles, really trying to educate and study women's heart health and in general women's health. Next slide. Thank you. Questions?
Thank you so much, Claire. And if anybody has any questions, you can enter them in the Q&A feature at the bottom of your screen. Looks like we have one already. Alrighty. Claire, can you hear me?
I can.
All right, I'm just going to read this one off to you. Since electrolytes have additional sodium while on meds for blood pressure and cholesterol, should you avoid taking additional electrolytes when doing cardio workouts to stay hydrated?
So that's a very specific question, and I would have to know more information about what medication you're on, what your electrolytes are. So I'm going to defer that to your cardiologist or your primary doctor, because I wouldn't do a good job unless I knew all the information, and I don't have all the information in that, but I would definitely not take any over-the-counter medicines until it's cleared by your doctor or your cardiologist if you're on any kind of medicine that does affect your electrolytes. Hope that answers your question.
All right, that's the only question at the moment, but we'll give it
Okay.
a few more seconds here to see if anybody else has anything. All right, that might be the only question we have. Oh, okay, here we go. Does dental health have a risk factor?
So I didn't address that in this, but in general, my brother is a dentist, so he has educated me on dental health, but I would say yes, in general, if you have infection in your mouth, or caries, that there is a link to infection throughout the body. And one of the places that infection can occur is your heart and your heart valves. So in general, I would say yes. That's probably a very specific topic that needs to be, could be another Zoom meeting. I don't know if that answers it. Yes, I would say brush your teeth, floss, you know, um, see your dentist. My brother's retired, but I would refer at this point. So anyway, that's okay. Hope that answers the question.
Do the hot flashes that accompany menopause cause an increase in blood pressure?
I'm sorry, I didn't hear the first part.
Do the hot flashes that accompany menopause cause an increase in blood pressure?
Um, I think that there's um, it doesn't necessarily increase your blood pressure. It certainly feels like that. You feel like you're on fire and that everything's high. It can lead to some high blood pressure, but there's a vasomotor, so what does that mean? There's a whole hormonal situation going on, but it can raise it a little bit, but specifically that's it's postmenopausal that you're more at risk. Um, I would say I would still, as you go through menopause, make sure that you get your cholesterol checked, that you get your blood pressure checked, that you see your primary doctor, and that if any of those are out of whack, you ask for a referral to a cardiologist or a nurse practitioner. Um, and if you're concerned that you feel that it is happening, I would speak to your to a primary doctor and also bring that up with your GYN and have them converse about what to do and what the next steps are. But in general, it feels like your blood pressure is off the hook, and that but in general, I would say there is some of that, but I don't know for a fact. I didn't check my blood pressure during the hot flashes that I had.
Does Mather have heart health / cardio exercise classes?
They have a cardiac rehab that's specific for patients that have had come through with a heart attack or some kind of heart failure. So we can certainly check on that. It's actually only been open a couple of weeks. I don't know whether you can go directly there. If you have to have a referral from your cardiologist, and then it's covered by your insurance. So, but shoot, sorry. I think I just dropped out. Okay. They do have a cardiac rehab program for specific cardiac patients. So if you've had a cardiac event, insurance can pay for it. I hope that answers it.
Next
And we can give
question.
you information about that rehab. I just don't know who's able to go to it. I do know my cardiac patients are referred there and covered by insurance. Go ahead.
Sorry, next question here. I was recently diagnosed with non-constructive CAD. I now take 40 milligrams of, I'm going to butcher this, atorvastatin, and my
Yep.
LDL is now 63. What can I do
Excellent.
so my numbers don't get worse?
That's an awesome number. And non-obstructive disease is it's a good way to treat with cholesterol pills. So unfortunately, it's very basic. I would continue to take your medication. I would daily do some form of exercise if you can. I know it's hard. Um, and I would follow up with the cardiologist to see how and obviously diet. Um, diet is it's not a specific food, it's your general foods, and really trying to be a label reader to see what's incorporated in the foods we eat. I often tell patients that they need to eat more whole foods, meaning less or more around the periphery of a food store, and that's the fruit and vegetable area, the lean meats and the dairy, and then the middle is filled with all the junk, and that's the potato chips and the cookies, and that all has hidden fat, sugar, and cholesterol. And I tell my patients that if it's low in fat, it's high in sugar and salt. If it's low in salt, it may have sugar. So just be a label reader. And I think cholesterol level of 60 is doing pretty well. Continue on your medicine. I'm a big believer in cholesterol pills. Next question.
Does your cardiac risk rise earlier if you have had early hysterectomy or gone into menopause early?
It depends on, it does go up if you have no hormones. It depends on if you had a total hysterectomy. So you potentially could have earlier cardiovascular risk, cardiovascular events because you were in earlier, you had your hysterectomy. So you need to talk to your primary and talk to your GYN about what your risk factors are and whether you should be referred. That's the big message here, is that earlier intervention and management of some of our risk factors, and awareness, education, that if you've had a hysterectomy, but was it a total? Did they take all your ovaries? So there's more to that question. And that's a question you need to have with your primary and your GYN and have them speak together. Next question. I hope that answers it.
What is a good age for a cardiac score test?
Well, right. So I would say that depends, right? So I couldn't give a specific age. It depends on your family history. It depends on all the risk factors that I talked about. Family history, do you smoke? Are you overweight? Or do you have high blood pressure? But in general, I'd say having the pertinent conversations with your primary doctor early and making sure you do get to the primary doctor. As I've emphasized here, is that as a woman, we're always last. So we get everybody else to where they need to be. But I would say in general, I would talk to your primary doctor and see if you do need a referral and what age. I would say if you're in menopause and you have a lot of risk factors, I would start having those pertinent conversations. You want to get preventative medicine and prevent the acute events. And I say this every day to my patients, that I'd rather you walk in here with a test versus an emergency. So I don't have a number, sorry. It depends on your situation.
Sorry, Claire, there's just an update from the person with the question. She specified with no family history and in good health.
I would say, I'd have to have more data to give her recommendation. So I would talk to her primary. It's hard to give a recommendation. I would say once you're off menopause, after menopause, at least start to have those conversations. It depends on your cholesterol level, your sugar level. Everyone's idea of what a good health is very different. Skinny doesn't mean necessarily healthy. So you need some data from what your blood pressure, your cholesterol, your sugar, your thyroid. There's more to, it's hard to make that decision, but I would say after menopause, right after menopause, but you need to have those conversations with your doctor.
Would using supplemental omega-3 help your heart health?
I'm sorry, using what?
Supplemental omega-3 help your heart health?
There's a um so back when I first started doing cardiology, omega-3s were like the big thing, and then what really omega-3 is in fish. So instead of taking pills, I would encourage you to eat more fish, which sounds annoying because not everybody likes fish, right? But I think some physicians think that omega-3 is okay. I haven't really seen studies specifically for women. Um, and whether you're wasting your money or not on omega-3s, they can be expensive. Um, so I would say I would eat a more balanced diet, incorporating more of the omega-3s in your diet. And I know that maybe not the answer you want, but because if you don't like fish, you don't like fish. So next question.
Do you recommend hormone replacement therapy for heart health?
Um, I'm not here to make any recommendations. And I would say in general, that needs to have a conversation with your primary doctor and or a cardiologist. And in general, initially it used to be thought that it was protective, but there's risks involved in taking hormone replacement therapy. And that's a larger conversation and someone who's more of an expert in this, but I would say in general, I would speak to whoever prescribed them, and then it depends on what your risk factors are, right? Do you have family history? Do you have high cholesterol? Do you smoke? Um, have do exercise? And then you're taking hormone replacement on top of that. Hormone replacement tablets have come with their own risk. Every tablet, whether it be over the counter or pills that we get from the doctor, do come with risk factors. So it depends on your other risk factors. So it would be very hard for me to answer that as a general question.
All right, this looks like it seems to be the last question. My GP referred me to a cardiologist, and I went and got my LDL down to 63. But my GP wants me to also take a low dose aspirin, and my cardiologist says it's not necessary. Who do I listen to?
Um, so debate, right? So aspirin, so there's a lot of information there, but there's a lot of information I don't have. So um, so aspirin for years and years and years was thought to be cardioprotective. And then there was a huge study that said, maybe we shouldn't give aspirin to people, and this is the cardiology world, unless they have coronary artery disease. So, and that, so your GP for years and years may have prescribed aspirin because that was what was prescribed. And now the cardiologist has looked at these studies and said aspirin doesn't come with zero risk. And so I, I would maybe go with what the cardiologist says. But again, I need more information about what your heart health is. And then ask the cardiologist specifically, can you give me the data why you don't think I should take it? I don't know if that answers you. It's a hard decision to make when you get conflicting information. And but the cardiologist's heart at the heart of the matter is that aspirin is not as benign as we thought it was. So hopefully that answers it. Okay.
All right. Well, thank you so much, Claire. That looks like
Okay.
it was the last question.
Okay, great.
Yes, so thank you for everybody joining. If you have any additional questions, you can email them off to matherhospital@northwell.edu. Once you exit the webinar, you will see a link to complete a brief survey. If you could please complete the survey, your feedback is extremely important to us and helps us plan our future programs. Thank you all again for joining, and if you'd like to view past HealthyU webinars, you can view them at www.matherhospital.org/HealthyU. Thank you all for joining. Thank you so much, Claire, for that amazing
Oh, thank you,
presentation.
Jonathan. I appreciate all your help with my technique.
Absolutely. And have a great day, everybody.
Thank you. All right.